Another thing you asked me about was what else is exciting at the meeting, and I think there is a ton of exciting stuff going on at ASCO this year. The couple things that have struck me is in GI in the past few years, there's been this lingering question of, can we reduce the amount of adjuvant therapy that we give people with colon cancer? And so there was this large international study, IDEA, that looked at FOLFOX versus CAPOX and 3 months versus 6 months. And I think the punchline that came out of that a couple years ago is there is this subgroup of people, these early stage 3s who have one node and who are T3N1s, where you can give 3 months of CAPOX and you can have outcomes that are similar to 6 months of adjuvant therapy, which has been our standard for years. So that was obviously a hugely exciting finding, and everyone's trying to sort of figure out if we can identify more people beyond just these T3N1 stage 3s. So there were some nice data this year looking at high-risk stage 2s, which are essentially a group that are close cousins to these stage 3s. And what they showed in that data, in those data at this point, was it also looks like CAPOX 3 months may be a nice option for that group of people. But one thing it didn't show, and I think everyone's struggling with this, is that actually in these stage 2s, these high-risk stage 2s, a lot of docs were going to potentially using just capecitabine alone, and the data don't show that. So I think people have to be really careful about practicing within the guidelines and practicing within what the studies have shown. So I think what we'll see for high-risk stage 2s is that CAPOX will hopefully become an option for that group as well for 3 months. I thought one of the other interesting finding out of that is they looked at some subgroups, and the MSI high subgroup, which is of course this super exciting subgroup for immunotherapy, didn't actually seem to generate as much benefit from the therapy as the other group again. And we've seen this story for a while out of Dan Sargent's work with the Accent database and some of the early studies from Ribic, that even though MSI high colon tumors are generally the ones you want to have because they tend to have better prognosis, and now we know they tend to go to nodes less often, and now we know they have immunotherapy as a possible treatment in metastatic disease. Our traditional chemotherapies in some settings don't seem to be as effective in that group, and it's probably because of the underlying DNA repair defect. Chemotherapies traditionally depend on some of the mechanisms that cells use to repair DNA, and because they're malfunctioning in these tumors, our chemos don't work as well. So I thought that was also exciting, but there's so much good stuff coming up at the conference. We have to keep our eyes open for more.